Hello, I'm Dr. Sean OMara, an emergency medicine physician with the United States Army Medical Corps Project Medic, here to demonstrate an important development in airway management through an innovative airway device that we have developed through the Army, which we hope will significantly increase healthcare providers' ability to manage airways safely by significantly decreasing the time to intubate a patient emergently, reducing the complication rates of endotracheal intubation, and significantly improving the rate of successful first attempts at securing an airway. The device that we've developed in the Army compares very favorably to the conventional approach to airway management through endotracheal intubation, and offers a significant reduction in costs to conventional endotracheal intubation. Currently, we perform endotracheal intubation through a standard endotracheal tube that's loaded with a metal stylet. The metal stylet itself runs for anywhere from about $1.50 to $3.50 added expense or cost to an endotracheal intubation, and requires a healthcare provider to intubate in this manner. One of the problems that we detected right away with endotracheal intubation through an analysis of difficult intubations that we conducted at Fort Sam Houston, looking at either prolonged attempts at endotracheal intubation or intubations that resulted unintentionally in esophageal intubations, was that the healthcare provider's view was significantly obscured by the endotracheal tube itself. For instance, the healthcare provider may have the cords visualized, but as soon as they enter the oral pharynx, they, with the endotracheal tube, they immediately have their vision of the cords obscured by the endotracheal tube itself. I'd like to now demonstrate this process compared to the device that we have developed, the OMara tube, which stands for Orally Maneuvered Airway with Removable Applicator. The OMara tube significantly reduces the incidence of obscurity of the endotracheal laryngeal inlet by its smaller diameter and much easier use of an intubation guide. So let's go ahead and take a look on our monitor. I'd like to now turn your attention to our monitor so that you can visualize from a healthcare provider's perspective what is occurring during this attempts at oral endotracheal intubation. Here we have a nice view of the vocal cords, the laryngeal inlet, which a healthcare provider may see, and we can now see what a standard attempt at endotracheal intubation looks like. Quickly, as the endotracheal tube comes into view, you can see that the cords are immediately compromised, the view of the cords, by the endotracheal tube itself, which blocks the healthcare provider's ability to see the cords. The endotracheal tube itself, too, because of its large diameter at the end, allows for the cord, the endotracheal tube rather, to be hung up on some of the soft tissue structures that are present in the oral pharynx. Now, with this new device, we can significantly improve the ability to endotracheal intubate by now using the OMara tube. The OMara tube comes with this extension catheter intubating guide that's indwelling within the endotracheal tube and allows for quick and easy intubation of a patient. Where the intubation guide goes, the endotracheal tube that envelops it will follow. What I'd like to point out too is the ability to retain a high degree of control and place the intubating guide exactly where you want to place it because of the unique design of the OMara tube, allowing for a high degree of manipulation and control on it. This again to demonstrate endotracheal intubation is easily performed by this technique and device. All right, thank you very much, Captain Allen. The OMara tube comes in several different versions. because of its smaller design, we were able to achieve a difference in catheter size and vary it so that we can use different size endotracheal tubes over it. For instance, we can take a much smaller diameter size tube and then include it within a smaller neonatal infant endotracheal tube, and now offer this device and this technique in neonatal infant patient populations. Additionally, the device also allows for a slightly different version, which we term the trauma version, which is very helpful in a situation or setting of an ongoing hemorrhage, so an actively bleeding patient. You may encounter a patient who has an active bleed in their oral pharynx, which obscures the healthcare provider's ability to see the cords. Presently, a healthcare provider has to go in and suction first out with suction tubing, then come back out and come back in with an endotracheal tube, and hopefully try to secure the airway. The problem is, in the interim, from suctioning in the first place to clear the cords, and then going back out and getting an endotracheal tube, the cords are often once again been obscured by an active bleed. Now with this device, on the proximal end, it has an open channel continuously throughout the device, so that suction can be hooked up to the proximal end, allowing the healthcare provider to immediately suction as they go in until they see the vocal cords, and then to intubate with the device, securing the airway instantly, even in a difficult situation such as an ongoing active bleed. Another version of the device is with a use or employment of very inexpensive fiber optic technology that's presently widely used in pelvic speculums. These pelvic speculums are less than $1 and employ very inexpensive low-intensity lighting that is transmitted throughout the length of the pelvic speculum. The same technology would be employed in the OMara tube, where low-cost fiber optics would transmit light through from the proximal end to the distal end, where the source would provide illumination for a healthcare provider to focus in exactly on their target anatomy. So as they're going in, they're able to visualize the cords through the use of the device. The advantage to this is that we will no longer be required, if you use this disposable system, to use an expensive laryngoscope. Laryngoscopes are initially a costly device to purchase and to begin with, but their significant cost is more associated with the maintenance of them, particularly sterilizing these blades, replacing the light bulbs on the handles, blades, and replacing the batteries and performing the regular maintenance that's required. Anesthesia techs and other technicians in the hospital are required to be employed just to attend to these matters. So this is a very labor-intensive and very costly system to maintain. By using a completely disposable system with a fiber optic light delivery system that costs less than $1, you can now have a completely disposable item, so that as a healthcare provider goes in, he doesn't have to have an expensive blade. He simply has an L-shaped curve, just in the same similar shape, that's made from a hardened plastic material that can be less than 5 cents to manufacture, because it's simply a handle that goes in to expose the oral pharynx. Then the healthcare provider can go in, providing illumination, and intubate the patient with a completely disposable system. The benefit to this is that it saves considerable amount of money to healthcare administration systems because of the ability to dispense with laryngoscopes. After the patient has been intubated, the disposable light optic portion of it can be thrown away, and the endotracheal tube remains indwelling within the patient. I'd like to also demonstrate that this device, in addition to being very useful for just the standard everyday intubation that might be encountered in the OR, because of its considerable cost-saving benefit, this device itself is only pennies to add to a standard endotracheal tube versus the considerably much more expensive metal stylet. It It allows for the healthcare provider to intubate a patient even during an unexpectedly difficult airway, such as perhaps in the OR when you're not expecting an airway to be difficult, or more likely out in a pre-hospital setting, or perhaps in an emergency room where you encounter a difficult airway. A difficult airway here, in this case, being demonstrated by a healthcare provider's inability to see the cords because of their limitation of their view or soft tissue swelling. The healthcare provider may only be able to see perhaps the epiglottis. In these situations, typically what happens is a healthcare provider will change their laryngoscope now under conventional approach from perhaps a Mac 4 to a Mac 3, or from a Miller 3 blade to a Miller 4 blade, trying different size blades, different shapes blades, and then ultimately employing perhaps other modalities such as fiber optic intubating systems, very expensive, or combi tubes, laryngeal mask airways, perhaps retrograde wire intubation, or ultimately surgical cricothyrotomy may be necessary. All of these add, unfortunately, time and even more unfortunately, the potential for hypoxic brain injury to the patient in the event of a prolonged intubation. However, now with this device, a healthcare provider can quickly and easily secure the difficult airway, even on their first attempt, by going into the oral pharynx and counting the epiglottis and manipulating the easy-to-guide tip of the intubating guide just along the posterior aspect of the epiglottis in an anterior direction. This allows the endotracheal tube to be inserted within the trachea, even when the vocal cords are not able to be visualized. The two criteria under these circumstances the healthcare provider takes advantage of to confirm that they have endotracheally intubated the patient is, one, through tactile stimulation, they are able to appreciate the cartilaginous rings that line the anterior surface of the trachea. The only other place that an endotracheal tube, or any tube that's placed into the oral pharynx, is going to end up when it's advanced is either into the trachea or into the esophagus. So if you're not feeling the cartilaginous rings, then you're not in the trachea and you're in the esophagus. The other criteria that is necessary for the healthcare provider to appreciate is, with slightly further advance of the catheter, you will feel what we call carinal hang-up, or mild resistance to further advancement of the device. At the takeoff of the right and left bronchus, as smaller airways are encountered, the guide will no longer follow the natural course of those smaller airways and begin to hang up. That resistance will not be encountered in the esophagus, for if the device and the endotracheal tube were in the esophagus, it would simply continue right into the stomach. This is a very important advancement in airway management because it no longer means that we have to confirm endotracheal placement by placing the patient at risk for potential aspiration by bagging the patient up to establish that we've endotracheal intubated the patient. We can confirm endotracheal intubation of the patient by those two criteria first, so that we know reliably through these very specific and very sensitive criteria that we've endotracheal intubated the patient. Presently, under conventional approach, even in the most sophisticated trauma center, we cannot confirm endotracheal placement without doing capnometry, which requires bagging and looking for a color change or looking for a capnogram 5 proper wavelengths. Now we can confirm through these two very easy, quick to establish, and reliable criteria to confirm endotracheal intubation before we begin bagging, before we place that patient at risk for aspiration. I'd like to now demonstrate for you the other added feature to this device, which is its capacity for permitting intubation even without a laryngoscope at all. And I'm going to now demonstrate digital intubation blindly to further show that no scope or visualization is even required. Encountering a patient now who has need for an airway, I can very easily, because this is so easy to manipulate, introduce this catheter into the oral pharynx, and in seconds I have intubated this patient digitally without the need of setting of a mass casualty where or a laryngoscope is not available at all for a variety of different reasons, you now have the capacity to secure an airway quickly and easily through this digital method. This method can be enhanced even further by use of a military setting where, as physicians in the Army, we may be challenged to intubate patients under less than ideal circumstances, actually in a hostile environment, where we may have to, in fact, be donning gas masks. Secure airway. And I'm going to demonstrate the capacity to still digitally intubate this patient, even with these thick Mach 4 level rubber gloves on, the highest level of substance chemical protection we can go into in the military. Even in a blinded situation where I have now no capacity for seeing. Lost my airway. Okay. So I cannot see it all. And I can still very quickly and easily intubate this patient, even with these thick rubber gloves on. Confirming endotracheal intubation. So I know that I reliably intubated that patient before I removed my catheter. So in zero lighting, even with this thick protective gearing, you can still endotracheal intubate this patient. So after demonstrating this device to you, I hope you can appreciate the value to its as an adjunctive airway measure, that simply adding this small piece of plastic to any standard endotracheal tube allows you to supercharge an endotracheal tube into a turbo tube, so that you now have not only a typical standard endotracheal tube that costs less than a conventional endotracheal tube under the conventional method of endotracheal intubating, but you now have a very high-speed rescue airway device built into it. This significantly improves its ability to manage an airway, secure an airway for all healthcare providers, both in the operating room under standard controlled circumstances, as well as out in the pre-hospital setting. We feel that this is a significant advancement and